that will be following my talk. So, so I'll be sharing my screen, and next 10 to 15 minutes I'll be talking about the overview of short stature. So let me quickly go to share screen. Yeah, I hope my slides are visible.
Yes, sir.
Yeah, sure. So these are the disclaimers that the content of this presentation is only for the healthcare professionals, and this is just for information purpose. The clinicians are requested to take informed decisions based on their own assessment of patient. And there are a few slides that I have added of my own experience over last 10 years. So epidemiology and pathophysiology of short stature. So whenever we are talking about short stature, what do we mean by short stature? So all of us are aware that it's a statistical definition, just like any biological variable, be it height or weight or hemoglobin or any standard biological variable. When you put this variable on a Gaussian curve, you define the median value, and then you define the standard deviation along the median values. So short stature is defined as a height that is 2 or more standard deviations below the mean or median value for the age and gender within the population. So we are now talking about a certain population, for example, children that belong to Indian ethnicity. So we cannot compare an Indian boy or Indian girl with Caucasian standards such as the CDC chart. So we need to be defining short stature using our own data. And in our case, we all of us agreeably use the IAP, Indian Academy of Pediatrics growth charts. So that's the reference population. Now, age and gender matched population. So whenever we are defining short stature, we are comparing that boy with the particular age matched boys. So it will be not fair comparison if I compare a 10-year-old boy with the 10-year-old girls from his class, because the girls might be actually taller on the 10th birthday because they are entering puberty. So we have to compare the child's growth with the age and gender matched population. So statistically, for any given population, around 2.5% of the population will be defined as short. So it's just statistical definition, not necessarily meaning that those 2.5% population are actually sick or all of them are suffering from any disease. It is not like that. Maybe those 2.5% population is actually healthy, but due to that statistical cutoff defined as third percentile or 2.5 percentile or 2 standard deviation, that population will be defined as short. So in developing countries, when you're comparing the developing countries like India with the standard population of Caucasian or American origin, you will have tremendous inflated numbers of short stature, such as these studies that I am quoting. So this one particular study, this is an old study, but it compares the Indian population with the WHO reference, where the stunting and wasting is severely inflated. Around 30 to 38% of boys and girls were shown to be short in the previous data, and 9 to 11% of boys and girls were defined as short from another study. These were children from southern Indian origin now living into UAE. There have been studies where they have shown that increase in per capita income. So per capita income, when it increases by 3 to 4%, your height gain over the average happens by 1 centimeter. So there have been studies, and the CNNS data, the current CNNS data also speaks about the per capita income and the height that is gained. So in general, betterment of the society in terms of education and affordability and per capita income has got some benefit on the stature. So if I have to quickly quote the various studies, there have been studies that have shown that protein energy malnutrition and chronic diseases are by far the commonest causes of short stature in Indian population. After that, we have the normal variants of short stature, such as your familial short stature and constitutional delay in growth and puberty. Then we have endocrine problems contributing to only 5% of the children that walk into our OPDs. So although we speak a lot on growth hormone deficiency, hypothyroid, etc., in a day-to-day practice, most of the children that come to us labeled as short stature are actually not endocrine diseases. So this particular tertiary care hospital from Kolkata has reported that around 29% of them had hypothyroid, 20% had chromosomal anomalies. But then this is a referral bias. When you are analyzing the data from tertiary care hospital, you will see a lot of children with endocrine problems. Whereas if you analyze the data from community, you will see that majority of these children who are short in the community are in fact having some underlying chronic disease or PEM. If you are aware of the National Family Health Survey, it happens every 5 to 10 years, they are updated. So the last NFHS data is published, NFHS 5 from 2019, and it showed that 35% of the children that were under 5 were stunted. Now this 35% that are reported are from the sample surveys that are taken from various communities, and 35% is in fact a worrisome number. But this reference data for under 5 is from the WHO reference data. Now CNNS 2016 data, that's the Childhood Nutritional National Survey on Nutrition, has reported as 35% under 5 stunting, 22% as stunting between 5 to 9 years, and 26% of children between 10 to 19 years were found to be stunted. But the again reference data is WHO 2006 for all the population. So under 5, it's fair to compare with the WHO, but beyond 5 years, we must compare with our own data, and then probably these percentages won't seem that bad. So 22 and 26% is quite inflated number because the reference population here is WHO. Coming to common causes of short stature, and I'm sure that Dr. Jhalak is going to highlight all these factors through clinical case scenarios. But just to give you a highlight, hypothyroidism and growth hormone deficiency are the most common endocrine causes of short stature. If you talk about nutritional causes, anemia is by far the most common cause, and Dr. Akanksha and Dr. Jhalak would agree that most of the girls that come to us with short stature do have underlying anemia. The NFHS 5 data has again showed the same percentage of anemia to the tune of 50 to 55% in adolescent girls. So one must look for anemia. SGA, Dr. Akanksha is going to deliberate on upon, so I'll not speak much on that. So, but SGA is one neglected chunk of population where they, often fail to catch up and end up being very, very short. A girl coming to us in OPD who is otherwise healthy but has remained short, one must think of, genetic disorders such as Turner syndrome. But if you talk about the most common causes, the constitutional delay and familial short stature are by far the most common causes of short stature. This is my own data over last 10 years or so. I have analyzed this data almost some 9-10 months ago, where I have seen around 1173 patients that came to me with short stature. 13% were constitutional delay, 21% were familial, 26% were the SGAs, and remaining you can see smaller percentages, very small percent as skeletal dysplasia, less than 1%, and syndromic children contributed to around 6% where short syndromic children. So familial short stature, as the parents are short, the children are also bound to be short. Important factors to remember in familial short stature is their examination will be normal, their current height percentile will be tallying with their mid-parental height percentile, and there is generally no bone age delay in familial short stature, and their predicted final height based on their current height and bone age is similar to their mid-parental height. Idiopathic short stature, on the other hand, is a peculiar set of disorders where you don't know what is going wrong with the patient. So all the blood parameters are normal, the bone age is also normal, but yet the current percentile is much less than the mid-parental height percentile. And after ruling out all the major causes of short stature, you label these children as having idiopathic short stature. So there is a question in the chat box, when to use GH for SGA, and Dr. Akanksha is going to deliberate upon that. So I'm not going to answer that question right now. So maybe if we can discuss this at the end of all three talks. Endocrine diseases, GH deficiency is common in tertiary care centers where all the patients are referred, and the severest forms of short stature are seen when the person is having growth hormone deficiency. Hypercortisolism, either exogenously when the patient is receiving a lot of steroid for, let us say, nephrotic syndrome or some autoimmune condition, there you get short stature. Precocious puberty girls, during their early times as they are undergoing rapid pubertal changes, they seem pretty tall, but later on they remain short because their skeletal maturation happens very, very fast. Diabetes is on the rise, and we are all seeing a lot of patients with diabetes. If they are poorly controlled, their final height remains very, very short. There is something called as psychosocial dwarfism, where due to extrinsic factors, not nutritional, not endocrine, but because of the psychosocial negative factors, the child fails to grow. So normal variants we have already seen, familial short stature. There is something called as constitution and delay in growth and puberty, where there is a peculiar delay of 2 to 3 years in the bone age, and the child keeps on following the minimum percentile trajectory until around 13-14 years of age, and then the puberty that starts with a delay of couple of years, and eventually the child catches up on the percentiles and eventually would be reaching the mid-parental percentile or the target range, although on a lower standard deviation part. So lower part of the mid-parental height or target percentiles the child will be reaching. When you don't have any underlying cause for the short stature, you label them as having idiopathic short stature. How to measure the height? So up to second birthday, you would be taking the lying down length, because first is the child is not able to stand, and beyond infancy, that's between first and second year of life, there is a lot of physiological lumbar lordosis, and you would be measuring the height spuriously low. So as a dictum or as a rule, you would be taking the length for the children until second birthday, and you use instrument called as infantometer until second birthday. Beyond second birthday, you would be using a stadiometer, where you make the child stand against the wall, and all 4 points should be touching the wall. That is the heels, the buttocks, the shoulder blades, and the occiput. So these 4 points should be touching the wall, and don't forget to remove the footwear. We have seen even doctors measuring the heights with the children that are wearing their shoes on. So remember to remove the footwear. Socks are allowed. The socks, they hardly measure not more than 1 millimeter. So the person can wear socks but remove the shoes or chappals. And the height should be measured every 6-month interval, and the least count of your the scale should be in millimeters. So don't express it as 5 feet 2 inches. Always express it as 157.2 centimeters, etc. And what to compare it with? So for children below 5 years, we use the WHO data. For children above 5 years, we use the IAP chart. This is the formula for measuring the mid-parental height. So for girls, you would be subtracting 13 centimeters from the father's height and take the average. And for boys, you would be adding 13 centimeters to the mother's height and take the average. So father's height plus mother's height minus 13 centimeters for the girls and plus 13 centimeters for the boys. And then you divide the entire thing divided by 2. So this is how we get the mid-parental height. These are the growth velocity curves, and they depict the ICP model, also called as the infancy, childhood, and puberty model, where these children grow very, very rapidly during infancy and puberty. And during childhood, the growth is typically between 4 to 5 centimeters per year. So this you can all go through your standard textbooks. It's all available. It's important to know the growth velocity because you need to interpret the growth velocity as you have started to correct the underlying anemia or underlying hypothyroid or underlying growth hormone deficiency. The growth velocity should start picking up, and you should compare the growth velocity with the age group that you are treating. So it's important to look at the body proportions because you might be dealing with something called as achondroplasia or something called as MPS or mucopolysaccharidosis. There, the upper body and lower body proportions are going to give you the answers. And the growth velocity should be calculated every visit, and you should compare it with the annualized growth velocity should be compared. This is the IAP growth chart. This is the female growth chart. You can see 2 to 18 years. So the 2 to 5 years, the data is from WHO, and 5 to 18 is the data coming from our Indian studies. So these are subtle clinical clues where you can see birth weight or gestational age to know whether the child was SGA. Look for history of neonatal hypoglycemia, micropenis for hypopituitarism. So these clinical clues will be discussed by Dr. Jhalak, so I'll skip over. These are the head-to-toe clues, again will be taken care by Dr. Jhalak in her talk. These are the general investigations that one would be ordering, such as CBC, your creatinine, SGPT, and venous blood gas to rule out renal tubular acidosis. One important point to remember is growth hormone values are not to be ordered in the first go. Especially growth hormone is not a test to be done randomly. There is something called as GH stimulation testing, and to order this test, please take help of your endocrinology colleagues. MRI is to be ordered only when you have documented a low GH peak value on the GH stimulation testing, or you have any other clue to suggest hypopituitarism. This is a very, very nice flow chart available in all your standard textbooks. So please look for or endocrine problems if they are there, or evaluate for dysplasias if the person is not, if it is above a certain if the growth velocity is more than 5 centimeter per year with a delay, then probably we are dealing with constitutional delay. If the growth velocity is much less than 5 centimeter per year with a delayed bone age, then think of endocrine problems. These are the indications to refer the person to endocrinologist. The severest forms of growth hormone deficiency are often referred to us very, very late. So it's an appeal to all the listening pediatricians and physicians that pick them up early and refer them early so that the final height outcomes are better. So these are the ethical principles of therapy. So growth promoting measures should be taken into consideration after discussing the risks and benefit. The treatment has to be started on time and given for appropriate duration so that the final height outcomes are better. And the primary goal of treatment is attainment of normal height. Late diagnosis and suboptimal therapy is associated with poor final height outcomes. So pick them up early and refer them early. There are therapies such as growth hormone therapy, and in addition, we have IGF-1, anabolic steroids, GnRH analogs, and aromatase inhibitors that can be used with a limited role in improving final height in special scenarios. Please take help of your pediatric endocrine colleagues for such difficult cases. So the take-home message from my talk is short stature is a condition that is common, and it's a frequent reason for referral to pediatric endocrinologist. Correct diagnosis and evaluation is very, very important. There is a growing awareness that there is need for identifying the endpoints for growth hormone therapy. So now pediatricians are aware that there is something called as growth hormone injections, but you have to select the patient correctly, give the GH in correct dose, and have to be familiarized with the endpoints of growth hormone therapy. It's no point in giving the GH half-heartedly for maybe 3 months or 6 months. The person has to receive the benefits for specified endpoints. And clinical practice recommendations should be applied with consideration of the evolving literature, and these kind of educational programs that we all do should be helping the pediatric colleagues to make decisions regarding screening of short stature and referring them to their pediatric endocrine colleagues. So with this, I come to the end of the overview, and I take the pleasure of inviting my colleague, Dr. Jhalak Upadhyay. Dr. Jhalak Upadhyay has been working as a pediatric endocrinologist in Rajkot, Gujarat. She has done her MD from Jamnagar Medical College and pursued her fellowship in pediatric endocrinology from the Indira Gandhi Institute of Child Health, where she has done her fellowship, and she has also done her visiting observership at the Hospital for Sick Kids, Toronto, Canada, and also at Great Ormond Street Hospital for Children, London, where she has done her ESPE observership. And she has got a vast, degree of experience. She has been working in her endocare clinic at Rajkot, and she has several papers and publications to her credit. She is also active in IAP front, where she has been conducting various training modules at state and national level. So I welcome Dr. Jhalak, and Dr. Jhalak will be talking about the clinical case scenarios in short stature. So over to you, Dr. Jhalak.
Thank you so much, Dr. Tushar, for the kind introduction. You made my job easy because the initial part of my presentation was most of the things were covered by you. So I will be talking on clinical spectrum. Initially, I would like to discuss some theory part which is important in day-to-day practice, and then I would be going on to the cases. So let's begin. So why are we discussing about short stature? Why is it so important, and why are we concerned about it? Because it can be a sign of disease, disability, and a social stigma which causes psychological stress. Now, ICP module, Dr. Tushar already talked about, so I won't go into detail of this. So what are the anthropometric measures a pediatrician should record in his office practice? So when a pediatrician sees a child from 0 to 2 years, you are supposed to measure length, weight, and height circumference, and that should be at 0, 6, 10, 14 weeks, and later on 6, 9, 15, 18 months, where the child comes to you for vaccination. From 2 to 5 years, it should be height, weight, and head circumference. That should be measured every 6 months. And after 5 years, it should be height and weight with BMI. BMI, that is body mass index, which is calculated after 5 years of age. So this should be done every 6 months till 9 years, and then annually thereafter. SMR, that is Tanner staging, should be done every year to look for puberty in a child. Now, when we talk about measurement of height, it was already discussed that up to 2 years, even if a child stands, up to 2 years, its length, and you measure with this instrument shown here, which is called infantometer, and after 2 years, it's stadiometer. We do not use those wall mount pictures or the stickers for the height, but this is how we take the height with the use of stadiometer. Now, after taking the weight and height of the child, growth monitoring is important. So how do we do that? How do we monitor? So we use growth charts for that, and we plot those growth charts. It's simple, it's less time consuming. Why will I say less time consuming? Because taking a growth chart and plotting on it doesn't take much time. And these days, in this digital era, most of us in our OPD, we use software for the OPD purpose. So even if a dedicated staff, if we have for the height and weight, measuring height and weight of the child, when we enter it, we have growth charts even in our software, which we can interpret easily, or we also get directly, even if we don't have growth charts, they tell us where is the child falling in under which centiles, on which curves. So that is very easy these days. It's inexpensive and it's a great diagnostic tool. So what do we use? As discussed, from 0 to 5 years, we use WHO growth chart. And after 5 years, from 5 to 18 years, we use IAP growth charts. So this is how it looks. For boys, it's blue in color. And what we see here is weight, height, and head circumference. When you turn it behind, it's weight for length or weight for height. Okay. And similarly for girls, we have pink charts. Similarly, weight, height, and head circumference. And when you turn it at the back, we have weight for length or weight for height. Now talking about IAP growth charts, the Khadilkar charts from 5 to 18 years, boys again blue, where we have weight and height. And when you turn behind, for 5 to 18 years, we have body mass index, BMI charts, to look whether the child is overweight, obese, or normal. So after 5 years of age, we take BMI and plot it on the growth chart. For girls, it's again pink, similarly as boys, what we saw. These are the new growth charts which we have, which are combined WHO and IAP growth charts from 0 to 18 years, which can be used. Here, the simple thing is like they are easier to use because you don't have to calculate MPH. As discussed earlier, for MPH, we have a formula. But here, you don't need to calculate. If you're busy, you do not have much time in OPD, we have MPH percentile calculator on the right. Look at this. So what you do is you measure mother's and father's height and you put a scale here, and wherever it intersects on the middle line, that is the centile, and this centile is your MPH centile, and you plot it here at 18 years. This is where you plot the mid-parental height. So this is a very easy MPH percentile calculator given here. And here what do we have is weight for height chart. So in a busy OPD, if you're not able to calculate BMI, we have weight for height chart here on the left corner. Also, if you turn behind, you have a BMI chart, which can be used after 5 years of age. So these are the newer ones, which are at 0 to 18 years of age, can be used from 0 to 18 years of age, WHO and IAP combined, and are much simpler and easy to use, less time consuming. We also have growth velocity charts. So growth velocity means how much has a child grown over a period of time. So growth velocity we take over a period of 1 year, but you can also take at least for over 6 months. But it should be minimum over 6 months or up to 1 year. When is it abnormal? So these are the curves. When is it abnormal? When it's less than 25th centile, or it crosses 2 centiles, or the growth velocity is less than 4 centimeters in the prepubertal age. So the growth velocity is around, first year the child grows by 25 centimeters, then subsequently 12.5, third and fourth year is 7 to 9, fifth year onwards it's around 4 to 6 centimeters a child grows in a year. And during puberty, it's like around 7 to 9 centimeters in a year for girls and around 9 to 11 or 13 centimeters for boys. So how do we plot on a growth chart? So what do we do? Just put a dot, not a circle, not a cross. We just put a dot. So this is the age. If the child is 10 years old, I go at 10 years of age, I go up. This is my weight. I put a dot there. I go up, and whatever is my height, I put a dot there. So this is how I plot. I write the name, date of birth, and this is how I plot it. We just put a small dot. For mid-parental height age, this can be the formula which we can use. For the father's plus mother's height, divide by 2, plus 6.5 for boy, minus 6.5 for girl. So this is the formula, and whatever formula and whatever we get mid-parental height, that is That is what we plot at 18 years. So at 18 years, I go up and I plot it, and there is a mid-parental height range. So whatever mid-parental height I get, I have to add or minus 6. So plus or minus 6 of the mid-parental height I get, that is the range of the MPH. So MPH range I plot here, and my child should be growing within the mid-parental height range to be normal. So this is how I plot the mid-parental height range here. And we also interpret the height, age, and weightage. How do we do that? This is my dot. This is the height of the child. I go back till 50th centile, and then from 50th centile, I come down. So this is my height age. That is around 7.5 years. And weight, from the weight, this dot, I go back up to 50th centile, and then from there, I come down. So around 8.5 years is my weight age. So this is how we calculate height age, weightage, and I'll come to the significance of interpreting the height age and weightage of the child. So what else is important? First, the child has come to you for the component of short stature. You have taken all the anthropometric measures, plotted nicely on a growth chart. What else is important? History examination. So history, what do we ask? Duration of growth failure. Since when is the child not growing well? Systemic complaints, any systemic complaints. The child may have like polyuria, breathlessness, that is, the child may have renal tubular acidosis. So some systemic complaints the child may have, try to find out. The child may have some symptoms of malabsorption where you diagnose a case of celiac, and that is why the child is not thriving well. Dietary intake, remember nutrition is very important for a good growth. Also polyuria, polydipsia, for renal tubular acidosis, headache, vomiting, visual symptoms, any intracranial lesions or space occupying lesion, some pituitary tumors causing all this, these tumors, pituitary tumors, which are not letting the child grow well. So the height will be affected, child will be stunted. So that is also important. Any chronic disease, so that should be asked. Any liver issues or any chronic renal diseases, so that should be asked. And any history of cold intolerance, constipation, where I am lethargy, when I'm talking about hypothyroidism, suspecting hypothyroidism. So all this is important. Birth weight is important, where we are like SGA, what we discussed, premature child. So SGA, failure to catch up, that is why. Breach or asphyxia, any asphyxia at birth which has affected the pituitary gland. Neonatal hypoglycemia could be this could be a pointer towards your pituitary, multiple pituitary hormone deficiencies. Any edema hand and feet during infancy or during newborn period, which tells us child can have Turner syndrome. Consanguinity, social history, developmental history, if the child is a case of like a Down syndrome where you have a delayed development, so you know the child is short because the child has Down syndrome. Family history. So a lot of things are important here. So history, good history taking is important. All these points should be considered. When I talk about examination, height, weight, head circumference, upper segment to lower segment ratio, to look for the disproportionate short stature, dysmorphic features in a case of syndromic short stature. Systemic examination is important. Remember to measure BP and Tanner staging. That is to look for puberty. So after doing all this, history examination and plotting a growth chart, bone age is important. So for us, we always order a bone age, and we order for a left hand with wrist. So bone age complements growth assessment. It should be done. It speaks of the growth potential of a given child. There are various methods, to calculate the bone age. But remember, we don't calculate carpal bones. That is no longer used. And there are various methods like Grulich and Pyle, Bone Expert application software, which we have. And the most commonly used, I will say, is the Tanner-Whitehouse method. Now coming to definition of short stature, what is it? Whenever you plot the growth chart, the height, whenever it's below third centile, the child is believed to be short. Or when you calculate standard deviation, less than -2 standard deviation is a short stature. Height below 1.5 standard deviation of the mid-parental height, or if the child is outside the mid-parental height range, then it's again short stature. Even if the child is above third centile but out or below the mid-parental height range, the child is believed to be short. When I talk about growth velocity less than 25th centile, when I plot on the growth velocity curves, it's short stature. Or when I keep plotting on the growth chart and the child crosses two major centiles and comes down over a period of time, that is again abnormal, and this is believed to be short stature. So now coming to the causes of short stature that are physiological and pathological. Physiological, we have familial short stature and CDGP, that is constitutional delay of growth and puberty. Pathological, systemic causes and endocrine causes. So let's come to cases now. So this is a case 1 where we have a 10-year-old girl whose weight is 21 kilos, height is 122 centimeter. She is pre-pubertal, but when we calculated mid-parental height range, it was 146 here. 146 is here. So when we looked at the growth velocity, looked at the old height of the child, the previous records, what we find, the growth velocity was normal. 4 to 6 centimeter in a year, it's 5.5. The velocity is normal, but look at this. The child has familial short stature. This is the MPH and the range is plus or minus 6. So from 140 to 152, this is the mid-parental height range. So this is the range and my child is within the range. So this child is a case of familial short stature. That is a physiological short. But remember, even in a case of familial short stature, one of the parent may be extremely short or very short. It may happen that the one of the parent who is short may have a skeletal dysplasia which was not diagnosed, or a growth hormone deficiency which was not treated. So it is not that if the parents are short, child needs to be short. You also need to work up for the child if one of the parent is really short. So that needs to be done. Coming to case 2, what do we have here? This is a 13-year-old boy, weight 28 kilos, height of 135 centimeter. This child at 13 years is pre-pubertal. Mid-parental height range is good. The MPH is 169. Growth velocity is okay, 5.5 centimeter in a year. So that is fine. When we did a bone age was 11 years. So it is delayed. And there was a history of delayed puberty in father. So the grandmother says, okay, father was also had delayed puberty. The father had delayed puberty and had a delayed height spurt. After grade 10, he had a height spurt and he had a good height later on. So this is the history what they give us. So here we have history of delayed puberty in father, and look at this, child is less than 3rd centile, less than the mid-parental height range, a delayed bone age, all favoring constitutional delay in growth and puberty. So these are the 2 cases of physiological short stature. Now pathological, we have nutritional causes. Remember, nutrition is important. Nutritional causes. We have syndromic causes and endocrine causes, which Dr. Tushar already described. So I won't go into much detail of it. So let's go to investigations. So investigations, bone age is a must, as we discussed. X-ray left hand with wrist. Routine workup is important to look for any chronic systemic illness like CBC, ESR, doing renal function and liver function test, doing calcium phosphorus ALP. You may be looking at a case of rickets, and that is why the child has short stature. Doing electrolytes, urine evaluation. If you are suspecting a renal tubular acidosis, doing ABG, thyroid function test. Hypothyroidism presents with a short stature. Doing celiac test, doing total IgA and anti-TTG IgA if you are suspecting celiac disease. If a child has anemia, poor weight gain, short, you should go for celiac workup. Karyotype in girl. Remember, any girl presenting with unexplained short stature, karyotype is must. And special test is doing growth hormone stimulation test. Remember, baseline growth hormone has no value, and IGF-1 and IGF-BP3. But that growth hormone stimulation test should be done with the help of a pediatric endocrinologist. So now coming to case 3, we have a child whose height is 75 centimeter. That is minus 6.78 standard deviation. He is actually 5 years old, but the height is, 4 years old. Height is 74.9. Height age is 1 year old. Weight is 7.5. Weight age is 5 months old. The child also had mid-face hypoplasia, infantile face and voice, truncal obesity, cleft lip and palate, and micropenis. So any midline defects, you should look for midline defects. It may give you a clue of pituitary hormone deficiency, right? And this is how the growth chart was plotted. And look at this, child is very much below third centile. So here we have clues suspecting that there is midline defect and there is infantile voice and face, midfacial hypoplasia with a very retarded child in growth. The height is very much below third centile, less than first centile, and very much below -2 standard deviation, that is -6.78 deviation. So here we suspect growth hormone deficiency. The growth velocity of child was also abnormal. And what we did, we did routine workup, which was normal. We went ahead with clonidine stimulation test. And this is what we see. Look at all the results. We took 5 samples every 30 minutes and everything was below 7. Any value above 7 is normal. Everything was below 7. Remember, only doing baseline growth hormone one test in the morning, growth hormone has no value. Doing only IGF-1 even has no value. IGF-1, IGF-BP3 can be done, but growth hormone stimulation test is must to label a child having growth hormone deficiency. So when this child was diagnosed to have growth hormone deficiency, and when a child is diagnosed to have growth hormone deficiency, what we use is recombinant growth hormone therapy. The dose depends on the condition. Pens or vials are available. It's given daily sub-Q and usually in the night. There are adverse effects which needs to be explained. Enlargement of hands and feet, scoliosis, benign intracranial hypertension, slip capital femoral epiphysis, diabetes, dyslipidemia, concern for meningiomas and bone tumors. There's always a risk-benefit ratio that should be explained to parents. There are FDA-approved conditions where growth hormone is given, like growth hormone deficiency. Even for Turner syndrome, growth hormone works. SGA, where Dr. Akanksha will be talking on it. Idiopathic short stature, as discussed by Dr. Tushar. Prader-Willi syndrome and chronic renal disease. These are FDA-approved guidelines where growth hormone can be used. So now I'll be talking about this case. This was an 8-year-old boy who had short neck, broad chest. The hands were reaching almost up to knees. Family history, maternal aunt's son is short too. So we have these parameters here. The child is 8-year-old, weight, height, upper segment to lower segment ratio is 0.75, and the mid-parental height range. Look at this. Look at the growth chart. This is the mid-parental height range. Look at this. This is the height. This is the weight. So the child is short, less than third centile, below mid-parental height range. Upper segment, lower segment ratio is also abnormal. So this means we are dealing with a case of disproportionate short stature. So look at this. Disproportionate short stature, I was suspecting there is a short trunk. So when there is a disproportionate short stature, a short trunk, we ordered one X-ray spine. So skeletal survey is what we ordered. And when we got the X-ray spine done, there was typical humping of the vertebrae. Look at this. These. So this condition is spondyloepiphyseal dysplasia tarda. And how do we measure upper segment, lower segment ratio? From pubic symphysis to the heels is your lower segment, and you minus it from the height. You can also take sitting height with the help of stools which are available. So that is how you take upper segment, lower segment ratios. If you don't have, you make the child stand from pubic symphysis to the feet, the heels, you measure, that is your lower segment. The other radiological findings which we found in this child was platyspondyly, short femur neck, coxa vara, and signs of early arthritis. So this is how we came to a diagnosis of disproportionate short stature, and this child being spondyloepiphyseal dysplasia tarda. So this is the importance of measuring upper segment to lower segment ratio. Quickly, I'll move on to some spotters and then I'll hand over to Dr. Akanksha. So look at this. The typical phenotype here, what we see is a child who is short neck, web neck, then low hairline. Look at this, multiple navi, shield-shaped chest. They may or may not have the increased carrying angle here at the elbows, right? So we did this. Look at the X-ray. The fourth metacarpal was short. This is positive Archibald sign. So the fourth metacarpal can be short in a case of Turner syndrome or could be a pseudo hypoparathyroidism. So here the fourth metacarpal was short, and this is called positive Archibald sign. We did X-ray, look at this short fourth metacarpal, and we did a karyotyping. She's a girl with these typical phenotype, the features which I described with short fourth metacarpal. So 45X, and what we are dealing with a case of Turner syndrome. Coming to this case, short toes and fingers, almond-shaped eyes. Sorry, because I had to cover the eyes of the child, but the eyes were almond-shaped. This is very important, the birth history. Child was having low birth weight, difficulty in feeding, had hypotonia at birth. Initially, child was a failure to thrive child, difficult in gaining weight. After infancy, child had complaint of hyperphagia and then weight gain. Child is obese and having short stature now. So all these are the features of Prader-Willi syndrome, and Prader-Willi syndrome should be diagnosed as early as possible, because even in neonatal age group, when you have unexplained hypotonia, you should do MLPA for this child. And if you have diagnosed Prader-Willi syndrome, growth hormone is the treatment of choice and can be started as early as 2 to 3 months of age. And here, it's not according to weight, but as per the body surface area is how we calculate growth hormone dose and we give them. This is a very easy case, very easy spotter. Short stature, had complaint of increasing weight, had puffiness, complaint of lethargy, pallor, constipation, had cold intolerance, and when we did a bone age, the child had delayed bone age. So yes, here we are dealing with a case of hypothyroidism. Because this child is grown up, this must be a case of autoimmune hypothyroidism, because there is no delayed development, no mental retardation. And this child was diagnosed with hypothyroidism and treated accordingly. Here, look at this case. What do we have? Child came with complaint of short stature and mental retardation, was IUGR at birth, had microcephaly, cryptorchidism, bird-headed appearance. Look at this. So this is a case of bird-headed dwarfism, or also called as Sickle syndrome, right? And this case, this child presented with short stature, the IQ was normal. The child was born preterm, had feeding difficulties, triangular face, had facial asymmetry, had limb length discrepancy, and clinodactyly. So this is a case of Silver-Russell syndrome. Coming to this spotter, very easy. This child, look at the buffalo hump here. Moon face, had hirsutism and acne. Child had short stature with obesity, hyperglycemia, hypertension, purple striatum, myopathy, hypocalcemia. We all know it's Cushing. And it can be because of exogenous steroid administration or Cushing's disease. Short stocky build, short neck, round face, depressed nasal bridge, short fourth and fifth metatarsal, history of recurrent seizures, and they were because of hypocalcemia. This is a case of pseudo-hypoparathyroidism. So recurrent hypocalcemic seizures, you have to look for parathyroid disorders also, but here short stature with obesity. So how do we evaluate a case of short stature? If we have a disproportionate short stature, it could be short limbs or short trunk. Short limbs, a case of achondroplasia. Short trunk could be any affecting your spine, could be mucopolysaccharidosis. There are a never-ending list. Proportionate short stature, physiological or pathological. If physiological, you have to look at familial or constitutional. Pathological, look for the height age and weight age. If your weight age is more affected than height age, rule out any chronic systemic illness and any organic causes. If your height age is more affected, look for endocrine causes, do thyroid, look for the karyotype in a girl with unexplained short stature, do growth hormone stim test with the help of pediatric endocrinologist. Any dysmorphic features, rule out genetic disorders. So when do we suspect pathological short stature? When the height is less than 3 standard deviation, disproportionate short stature, there is retardation of growth velocity, child is growing less than 4 centimeter, The child, when you keep plotting on the growth chart and fall subsequently from falling off the growth centile curves more than 2 centiles, associated or increasing or decreasing BMI, dysmorphism, any other clinical pointers, and marked bone age delay, you have to suspect a pathological short stature and refer timely to a pediatric endocrinologist. So the take-home message is regular monitoring of height and weight is a road to health for children. Please, 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 please plot a growth chart. Even if that is not possible, put it in your software. That can be done easily, but at least have a staff, dedicated staff, to at least measure height and weight every visit when they come to it, at least 3 to 6 monthly. Make a habit of measuring height. Growth chart is a basic, inexpensive, and essential tool. Growth velocity is important, predicts growth over time and factors influencing it. Systemic evaluation helps in identifying the cause of the short stature. Karyotyping is must in a girl with unexplained short stature. Familial short stature, remember, one of the parent very short, it could be pathological. We need to rule out growth hormone deficiency or skeletal dysplasia when either of the parent is too short. Early referral improves outcome, so refer as early as possible. We know that if the child is in puberty or when they come after puberty, it's very difficult to treat the child for short stature. Thank you so much.
Thank you. Thank you, Dr. Jhalak, for that wonderful presentation. And your all cases were really, really very well worked up, and every case had a take-home message. Now, it's my privilege to invite. So I think we'll take the question answers in the end. Now I invite Dr. Akanksha. Dr. Akanksha Parikh is senior pediatric endocrinologist from Mumbai. She has done her fellowship in pediatric endocrinology at Rajiv Gandhi University of Health Sciences, Bengaluru, and she has been trained under Dr. Raghupati sir. She has also worked as a senior registrar at BJ Wadia's Children's Hospital. She has multiple, awards and honors to her credit. She has been a peer reviewer for the Indian Journal of Pediatrics and IJP, that is the International Journal of Pediatric Endocrinology. And she has multiple publications to her credit, including multiple case reports and also original research papers. So Dr. Jhalak is going to talk about the SGA, that is small for gestational age care, and the role of growth hormone. There was a question in the chat box. So I'm sure Dr. Akanksha is going to talk about the growth hormone and its role in SGA. Dr. Akanksha is currently working as a pediatric endocrinologist at Kokilaben Ambani Hospital, Mumbai. So I welcome Dr. Akanksha, and over to you.
Thank you, sir. Thank you for the kind introduction. I'll just share my screen. Yes, are my slides visible?
Yes, they are.
All right. So good evening, everyone, and welcome to today's talk. After two wonderful discussions by Dr. Tushar and Dr. Jhalak, we'll come to a more select cohort of patients, which are children who are born small for gestational age. And just to underline why is this cohort important, we've heard Dr. Tushar speaking about it. And just if we take some data from the Ministry of Health and Family Welfare website, we know that in India, we have about 25 million live births in a year. And of these, roughly 25% of babies are born small. And that basically is equivalent to about 6 million SGAs in a year, which is a huge, huge number. So with this background in mind, let's start with a case, and through the case, let's try and understand how we approach these children. So although we had a boy who presented to us much later, let's start with the birth history, where he was born 33.2 weaker. The mother had pregnancy-induced hypertension since 7th month of gestation. The birth weight of the boy was 1.5 kilos and birth length was 39.3 centimeters. Now, from this history, we do understand that this boy was born low birth weight, but the question is he born SGA? And to answer that, we need to look at his birth weight and length in comparison to the gestational age. And therefore, we need to look at some growth charts. So which growth charts should we be using? For term babies, so babies who are born term, as we've seen before, the growth charts to use are the WHO MGRS growth charts. However, for preterms, although earlier we used to use the Fenton's charts, now what is advocated are the Intergrowth 21 charts. And these are freely available online, so you can download them and use them in your clinic. Now, when we plotted this boy's growth, rather birth weight and length on the chart, we found that his birth weight was at the 10th centile. The birth length was less than 3rd centile. So let's quickly look at the definition of SGA. SGA, according to a neonatologist, is defined as the length or the weight. And here the highlight is or. So not just the weight, but even one needs to look at the length. And if the birth length or weight is less than the 10th centile, then the child or then the baby is considered as SGA. But for us endocrinologists, we more commonly look at babies who are born less than the 3rd centile, which basically is equivalent to less than -2 standard deviation. Also, when babies have IUGR along with SGA, these are babies who are more prone to get metabolic complications later on in life. So here the question is that, did the baby have intrauterine growth restriction along with SGA? And again, let's quickly look at the definition of IUGR. So if you have a baby whose growth velocity is normal throughout, then the baby is born appropriate for gestational age. But here we have a baby who is born small right from the beginning of the gestational period. And here, this is considered as constitutional SGA. Now look at this baby who was growing okay at a certain point, but after which there is a retardation of the growth velocity. So when we talk about IUGR, it's a dynamic retardation of the growth velocity, and we need at least 2 fetal sonographies to demonstrate the retardation in the growth velocity. So the question now being that if you have a baby who's born SGA, how often should we be monitoring their growth? And in the first year, we should be seeing the baby's growth at least once in 3 months, and after which 6 monthly till about 18 years of age. And this was covered by Dr. Jhalak, that however, a more practical approach would be to look at the growth of such babies at every immunization visit. So take the opportunity of the immunization visit to document not just the length, but not just the weight, but also the length. And after which 6 monthly, they can be followed up. Now, what are we looking out for when we are looking at the growth of these babies? What is it that we should be looking out for? And we need to look out for a catch-up growth. So what is catch-up growth? Catch-up growth is when the baby's length reaches 3rd centile. And mind you, reaching the target genetic height, as was outlined by Dr. Jhalak, is not a criteria for the catch-up, but they do need to reach the 3rd centile on the growth chart. So what do we know about catch-up growth and children who are born SGA? Now, 90% of the children do catch up by the age of 4 years. The maximum catch-up, however, occurs in the first 6 months of life. Beyond 4 years, if a baby who is born SGA has not caught up, then it's unlikely that he or she will catch up later. So if we ask that why is it, so what percentage of SGAs catch up? About 85 to 90% of them do catch up. If 10 to 15% of them do not catch up, then why is it that they don't catch up? And this could be for a variable number of reasons. One could be a nutritional component, as has been outlined before. But these babies can have some amount of growth hormone or IGF-1 resistance, which is preventing them from catching up. It's also possible that there are certain SGA, that is prenatal as well as postnatal growth restriction associated syndromes, which may be missed because of subtle dysmorphisms, and that may be the cause why the baby has not caught up. Can we predict whether this baby who's born SGA will catch up or not? There are certain predictors which tell us that a baby may not catch up, and that is that if the birth length is more affected than the birth weight, then these are babies who may not catch up. So if you have a short baby at birth, then they may not catch up. And also those babies who have a short mid-parental height, which means short parents, then in such cases, they may not catch up. There are certain factors, however, which do not influence the catch-up. So it doesn't matter whether the baby is male or female, or if the baby has asymmetric or symmetric IUGR. Even the gestational age of the baby has no influence on the catch-up, or if the baby had pregnancy-induced hypertension, like in our case, it will not influence the catch-up growth. So, is there a difference between term or preterm SGAs? One must remember that the proportion of children who catch up remain the same. It's just that preterm SGAs take a little bit longer to catch up as compared to term SGAs. And it has been seen that preterm SGAs, especially those who are born less than 32 weeks, the ones who catch up, they catch up but with a smaller magnitude. So at the end, when they reach their final height, they tend to remain smaller than their healthy counterparts. So let's come back to the case, and this is when we saw the case for the first time. So by this time, the boy was 5 years and 10 months old. You can see from the growth chart that he had short stature. His height was 99 centimeters, which corresponded to minus 2.57 standard deviation. Weight was at minus 2.7 standard deviation. And the mid-parental height was 167 centimeters, which is between the 10th and 25th centile. On examination, this boy had no dysmorphisms. So in such a case, if you were the pediatrician who saw this child for the first time, before jumping to the conclusion that this child is an SGA who's not caught up, as we've seen before, we need to rule out other causes of short stature, such as a nutritional cause, a chronic illness which may remain silent, such as a kidney disease or a malabsorption condition, as we've seen earlier, or endocrine causes or syndromes. So when we sent the baseline short stature workup, we found that all the investigations were normal. And therefore, our impression was that this indeed was a boy who was born small but had not caught up. Now, are these children who are born SGAs growth hormone deficient? And the answer is no. Most of them have a normal growth hormone secretion, but as I've said before, they may have a mild resistance. And to evaluate their growth hormone axis, which means to perform a growth hormone stimulation test in them, is not compulsory unless we find that they have a reduced height velocity for age, or there are certain other pointers such as midline defects, as has been outlined by Dr. Jhalak, such as cleft lip, cleft palate, a microphallus, etc. We do send an IGF-1 level in these children. It usually tends to remain on the lower end, and it's important not for diagnosis, but if we start therapy in them, then it's important for monitoring the dose of growth hormone that we give. So there was a question in the chat box, when do we give growth hormone to those born SGA? So growth hormone therapy has been FDA approved since 2001. And just again, a highlight that before you consider treating a child born SGA who's short with growth hormone therapy, one must rule out other conditions such as a chronic illness and an underlying other endocrine condition. Now, there is an algorithm, which can be followed, which is the child born SGA, yes, Is the age more than 4 years? Yes. Is the child's height less than minus 2.5 standard deviation? Yes, in our case. And is the growth velocity less than the 50th centile? For our child, for his age, the growth velocity average 50th centile was 7 centimeters per year, and he was growing less than that. So yes. And in such a case, since all the criteria are met, then we can discuss growth hormone therapy. So we did start growth hormone therapy in the child. And the question is, how well do these children do on growth hormone therapy? And 90% of them do reach their target height. And you can see here, this is just to sort of explain that when we did treat this child with growth hormone, over a period of time, you can see that there is catch-up growth, which is demonstrated. In fact, at the end of the 3 years, his height was 109 centimeters. And just for the sake of, a simplified explanation is, had we not treated, he would have continued to grow at the height velocity that he did. And the deficit in height at the end of 3 years would have been almost 6 centimeters. So, how are there any factors on which the response to growth hormone depends? Yes, it depends on the dose. A higher dose usually gives a better outcome, especially when the duration of treatment is short. And the earlier that we start therapy in these children, the better that we do. And again, this is just on the growth chart, just to demonstrate. You can see that if the therapy is started at a later age in these children, you can see that there is a slight catch-up growth, but you can make out that the height benefit after 3 years is much lesser than what is when we would have started at an earlier age. What is the dose of therapy that we start on? So the dose is actually a range anywhere between 30 to 70 micrograms per kg per body weight per day. Usually we tend to start at a lower dose of, say, 35. Is it safe? It's been seen in recent studies that the safety, it's as safe to give growth hormone in children born SGA as it is in children who are growth hormone deficient. The only sort of adverse effect which has been seen in this cohort particularly is that they can have some amount of glucose intolerance, but this is reversible. Once you stop the therapy, the blood glucose values return back to normal. Now, other benefits of growth hormone therapy in SGA, it has been seen that lean muscle mass improves, that visceral fat mass reduces, and there have been some studies which have demonstrated both psychological as well as neurodevelopmental benefits in these children. And what about puberty in children born SGA? So we do know that puberty influences growth, and what happens to children who are born SGA. So what has been seen is that this cohort usually has a normal age of onset of puberty, but the tempo of progression of puberty is quite rapid in them. And therefore, what is seen is that the bone age progression is quite rapid. Now, although the age of breast development or testicular volume increase is at a normal age in these children, they are found to have an early pubarchy, which means they can develop axillary and pubic hair earlier than 8 years of age in this cohort. And however, one needs to remember that growth hormone therapy does not influence the puberty onset or the progression. So when it comes to treating these children, by the time they reach the peripubertal age, there will be no influence on their onset or progression of puberty. Now, this particular case has been shown before, but this is just to demonstrate that in certain syndromic SGAs, even if growth hormone therapy was not given continuously, still this child did very well and responded to the therapy. And you can see that there's a catch-up growth, and she is coming close to her target height potential. However, this sort of good fortune may not be there for all children. Here is a child who has a syndromic SGA. The child was diagnosed as triple M syndrome, where some of the dysmorphisms could be a triangular face, relative macrocephaly, fleshy lips, skeletal changes. And here one can see that despite starting growth hormone therapy relatively early, the child failed to respond to the therapy, and the near final height was simply 148 centimeters, which is much, much below the target height for the child. And as we've seen before, that sometimes when we start growth hormone therapy in syndromic SGAs, it's not always for the stature, but more so for the metabolic benefits. And here is a child who was diagnosed with Prader-Willi syndrome. And although if you see, he was not short at the time of starting therapy, but the decision to start therapy in him was more for the metabolic benefits than for the stature. So with this, I'd just like to end, and few key messages from today's discussion is that for looking at SGA, one must use the Intergrowth 21 charts for preterm births and the WHO charts for term births. It's important to monitor catch-up growth regularly and use every immunization visit. 10 to 15% of the children do fail to catch up. And if you translate this into absolute numbers, this is a huge, huge proportion. And that growth hormone therapy is definitely much more beneficial if started early, and therefore picking up these children early is extremely important. With this, I end my presentation, and we are happy to answer any questions.
Thank you, Dr. Akanksha. That was a wonderful presentation. So we have a few questions that we will take, and meanwhile I'll request all the attendees to kindly type in their questions in the chat box so that the panelists will be able to answer. So you have already answered the question about when to start growth hormone. So you correctly pointed out that by the age of at least 4th birthday, if they fail to catch up, then one must consider starting them on GH. But in your practice, in reality, in Indian setup, in Indian setting, what is the average age that you see when they come to you and you start them on GH?
Yes, so to be very honest, sir, they do come much, much later. To be very honest, I've very rarely seen a child who's born SGA being referred at a young age of 4, 5, 6 years. Most of them come beyond, I would say, 10, 11 years of age, even 12 years of age, once puberty has started. And in such children, we don't have much time in terms of starting growth hormone and achieving the target height. So very often the decision in terms of starting therapy versus the benefit cost needs to be weighed, balanced, and taking all that into consideration, we would then go ahead with therapy or not.
Yeah. So Dr. Jhalak, are you there?
Yes.
Yeah. So Dr. Jhalak, you mentioned about syndromic short stature, and you mentioned about Turner syndrome, being one of the presentations where the person comes to you, the girl comes to you, otherwise healthy and
some network issues, I think, on his side.
Yeah, am I audible?
No, you are not.
Okay.
Yes.
So there are two questions pertaining to Turner syndrome. One is, at what age do you want to start these girls with Turner syndrome on GH? And the second question is, do you perform a formal GH testing in Turner syndrome before starting growth hormone?
So sadly, the same story continues with Turner syndrome. Very rarely they are referred early to us. So in my practice, if I say, I have seen girls with Turner syndrome coming for primary amenorrhea and not for short stature. Very rarely, like they come, but it's very late when they come. But most of the girls which I have are with delayed puberty, no secondary sexual characteristics, and that is why they have come to me with delayed puberty or primary amenorrhea, and that is why I've evaluated and found to have the child is having Turner syndrome. And then they had come at such a late age, like 17 years, 18 years, 19 years, that I didn't have any option of treating with growth hormone therapy. But if they come early, so Turner syndrome, they have short stature, they may not have delayed bone age. I will not go for growth hormone stim test. It's not required. You can start growth hormone and the dose is different as per the condition in growth hormone deficiency as well as Turner syndrome. So you can start growth hormone straight away. Doing growth hormone test is growth hormone stimulation test is not mandatory. As early as they come to me and whenever I find there is growth faltering, I should start with growth hormone therapy for the best of the result, because not all Turner syndrome girls will respond well to growth hormone therapy. Some may respond, some may not respond. So starting it as early as possible whenever there is growth faltering, and looking at the response, and then deciding whether to continue or not. But growth hormone test is not mandatory. Yes.
Yeah, thank you. So Dr. Akanksha, you spoke about SGAs entering into puberty early, and it's quite common. So do you see any role of GnRH analogs in such girls? And does addition of GnRH analog provide any additional height benefit in addition to your growth hormone therapy for these SGA girls?
Yes, I think
debate.
This is a sort of a gray area in pediatric endocrinology. I think I'll begin by saying that, because there are really no standardized guidelines which really talk about at what age, when the child enters puberty, can one use GnRH analog or not. But in my clinical experience, I do consider GnRH analogs in children, particularly born SGA, who present with precocious puberty or early puberty, where I do find especially that if the predicted height or the final adult height that we would calculate is will be low, in such children, one does consider GnRH analog. Also, especially when we see a rapid tempo of progression of puberty, that's again where we would definitely consider GnRH analog therapy along with the growth hormone therapy.
Yeah.
So here I would like to ask you, like, what is your experience? Because this we have been discussing many times about this thing, like using GnRH and growth hormone.
So I agree with Dr. Akanksha that although there is no clear-cut guideline, but then they often come to us with very much advanced bone ages. We don't know how much more centimeters are we're going to get, but definitely it will slow down the bone age progression. And if we are adding GH, so we'll get additional months or years for the GH to act. So yes, I also recommend GnRH analog in addition to GH. I mean, GnRH analog alone per se would not be much helpful in gaining additional height, but a combination of GH GnRH analog is worth considering. It is often said that there are some papers saying that addition of GnRH analog when the puberty has begun after 6 years of age will not add much to the final height. Yes,
only about SGA, but any child who is coming with precocious puberty, you would add both.
Yeah. No. So as Dr. Akanksha has already said, that if the final predicted height is much below the target height percentile, then we would consider.
Yes.
Yeah.
Akanksha, ma'am, you want to?
Yeah, I actually, sorry, but I wanted to just go back to the previous question about Turner syndrome, which
Yeah.
Dr. Jalak was talking about. There's just one little thing that I wanted to tell our pediatrician colleagues was that when we plot children with Turner syndrome, let's start plotting them on a normal, regular growth chart. And on a growth chart, regular growth chart, when we find that they are faltering in height, as Dr. Jalak pointed out, when they're crossing centiles downwards, that's when we would say that they have faltering growth. So we do have Turner's growth charts available, but we don't begin plotting on them. We plot them on regular IAP growth charts, and once they are faltering, then we can plot them on our Turner syndrome charts.
So Dr. Jalak and Dr. Akanksha, you must be seeing a lot of underprivileged children where they do need growth hormone therapy, but due to affordability reasons, sometimes we are unable to help these children. So for the benefit of attendees, would you like to quote any services or any government programs where you get growth hormone at subsidized rates or free of cost in your respective
For
states?
us in Gujarat, all our medical colleges give it free of cost. So we are very lucky. Most of them, almost all, I think, most of the government medical colleges give growth hormone free of cost. So once they come to us, to a pediatric endocrinologist, we write it and we send them to a government medical college. If there is an attached endocrinologist or a pediatric endocrinologist with that institute, they go to them, they again write it on their case paper from the institute, and then they get it free of cost. Yes.
I think unfortunately we don't have such services in Maharashtra. We don't have free growth hormone being provided at government health services. I think, correct me if I'm wrong, sir, but whatever funds that patients do get are either something that on an individual level they have strived for. So whether it's the CM fund or if it's a fund from the Rotary, etc. There really isn't, again, please correct me if I'm wrong. I don't think we in Maharashtra have a state-wise fund for growth hormone therapy. So am I right?
Yeah, so there is something called as Mahatma Phule Jeevan Dayi Yojana, where you have to prove that the person is having hypopituitarism. Sadly, GHD, alone are not supported. Many of our patients have been refused, saying that the pituitary is normal sized, and if the person is not hypopit, and they do not get. But is hypopits after documentation, some of them do get funds. But yes, I agree that there are not many programs that are available other than Mahatma Phule, and especially for non-GHD conditions, we don't get GH at all from these Mahatma Phule Yojana. Only for multiple pituitary hormone deficiency with if they have that small pituitary on the MRI, so they have a list of investigations that you must do. Otherwise, we don't have any support to these children. Yeah. So, any questions or comments so far from any of the attendees, or any comments from both of you, Dr. Akanksha and Dr. Jalak, about whatever we have discussed, or any closing remarks?
That's a request I would like to make, that plotting a growth chart is very important. And we know that it's difficult for a pediatrician in the busy practice, but at least if they have a dedicated staff who only measures weight and height on every visit, at least when they come to us, even if we have that record and not a growth chart, you can at least come to know what is the growth velocity or what were the previous height records. That's very important. So just a request on that. And referral of whenever you suspect that this is short stature and child is not doing well, the child should undergo evaluation and referral as early as possible for the treatment. That helps the best.
Yes, I was going to second that irrespective of what the etiology of the short stature, an early referral and an early chance for therapy always translates to a better outcome in terms of stature.
Yeah.
Yeah, thank you so much. And I think we are nearing the time limit, which is 10 p.m. So let me thank all of you, all the listeners, all the attendees for attending the session and for posting your questions. Thank you, Dr. Jhalak and Dr. Akanksha, for sparing time and sharing your valuable inputs, including your cases, real life cases that you all have shared. And I think the message was pretty much clear that plotting growth charts is important, picking them up early, using appropriate growth charts, disease-specific growth charts. There are certain steps where pediatricians can, actually intervene, but beyond that, it becomes mandatory to take help of your endocrinology colleagues. And luckily now we have pediatric endocrinology colleagues available in most of the parts of the country. So take our help. We are there to help your patients get better. I also thank today's sponsors for the event, Pfizer and Hydoc, for providing this scientific platform. And with this, I think if there are no more questions in the chat box, I think we can conclude the session. Thank you so much.
Thank you.
Thank you, sir.
Yeah.
Bye-bye.
Good night.
Good night.
Yeah, thank you, Dr. Tushar, Dr. Jhalak, Dr. Akanksha. Thanks a lot.
Yeah.
Thank you. Thank you.
Good night.
Thank you.